first session is acute and chronic heart failure from the European Society of Cardiology guidelines to Jordanian perspective. We have session coordinators. Raed, Akel, a friend of mine, a friend of most of us, could not make it. He told me he's stuck. I think he's in Palestine. Dr. Jamal Dabbas, our president of the Jordan Cardiac Society, I cannot see him, but that's all right. Chairpersons, Dr. Yousef, is he still around? I can't see him. When he comes, he will join us. Dr. Muhanad Ababneh will come. Dr. Rashid, Ibdah, welcome. Dr. Ayman, Hammoudeh. كأنه Mahmoud Izreiq is not here. He's out of town or something. Okay. Nael, Shoubaki, I don't know. I cannot see him. But anyways, why don't I turn the microphone to our colleagues. Dr. Ayman Hammoudeh, would you like to take it over and introduce the sessions, please? Thank you very much.
Thank you so much. So again, it's a privilege to start the first session, and I'll invite Dr. Ayman Hamdan to present his presentation on acute heart failure. Ayman is a interventional cardiologist trained at the USA, and he's in the private sector now. Ayman.
Thank you. Good morning. Can I have the first slide? Second. Oops. Okay, acute heart failure management. I got 10 minutes to go over this. First is patients with suspected acute heart failure, the symptoms, the signs, and the history of cardiac disorders. We do our ECG, we do blood work, we look at the natriuretic peptide, we do a lung scan or a chest x-ray, and the most important questions we should ask is the hemodynamic instability or stability of the patient. We look at his systolic blood pressure, mean arterial blood pressure, and his exam called extremities. If he is hemodynamically stable, then we look at his respiratory status, we look at the respiratory rate, the oxygen saturation, and the general condition of the patient. If that's stable, he is not in distress, then we use our diuretics plus minus the vasodilators, and we assist the patients whether he belongs to the ward or he needs to go to the ICU, CCU, whatever you call it. And keep in mind, heart failure is not a diagnosis. We don't diagnose people with heart failure. It's really a manifestation of an underlying condition. So we look for the underlying condition, what is causing these patients to come in an acute stage, whether it's arrhythmia, atrial fibrillation, hypertension, infection, medication non-compliance, or diet issues. We also look for medication upgrade if the patient needs his medication to be upgraded, and also we continue with the patient education because that's a very vital element in the management of patients with heart failure. If the patient has respiratory distress, then we go to our non-invasive positive ventilation, or if needed, we intubate the patient. Now, those patients who are harder to treat are the ones with hemodynamic instability. Those we use the inotropes, the vasodilators. Now, those people go to the ICU and we look for a cause. If it's an ACS, then they go to the cath lab. If there is a mechanical complications, they might go to the operating room. If they have arrhythmias, then we treat them with medications or electric shock. And if there are other causes like dilated cardiomyopathy, then we look for the cause. If the patient is in refractory to treatment or in shock, then if the answer is yes, we go to the mechanical support. Again, the management of acute failure, initial stabilization diagnostics, rapid assessment in the emergency room. There are time-sensitive approaches to the Akel, like acute coronary syndrome, proper transfer to the ED or CCU for diagnosis and initiation of treatment. The diagnostics, you do your ECG, your chest x-ray, your echo, biomarkers, Let's talk a little bit about the PNB or the NT-proPNB. Some people consider PNB is like your A1C for your diabetic patients. It will help you diagnose the patient, and if you treat, it will help you track if the patient is improving. And a very important aspect of the PNB is the prognostication. If you discharge a patient with a PNB below 100, then that patient, very likely he will do well. Compared to a patient who is discharged with a PNB more than 700, you know that patient is a potential 50–60% mortality within the next 5 years. Those patients need closer attention and closer monitoring. Oxygen and respiratory support tailored to the severity. We start with supplementing oxygen and if needed, non-invasive ventilation, CPAP, BiPAP if needed, and reserve for intubation. Now, the management of fluid overload. Loop diuretics is really the mainstay of treatment, the first line for patients with fluid overload, early, higher than home medication. You should almost always use 2.5 times the dose the patient is using at home. So if he's on a 40 Lasix, you probably have to hit him with at least 100 milligram. If diuretic response is inadequate, then you add your thiazide, acetazolamide. You resort to vasodilators like IV nitroglycerins, nitroprusside, if the pressure is high and the pressure allow you. And you always consider the add-on or device-based therapies for if symptoms persist. Your ACE, ARBs, ARNIs, if not already used, Ibdah, for patients with heart rate more than 70 beats per minute in sinus rhythm on maximally tolerated beta blockers according to the guideline directed medical therapy. And you assist those patients for ICD if his LV is below 35 and his life expectancy is more than a year, because obviously if they have a low life expectancy, those patients might resort to a palliative care. The CRT for those patients with left bundle or wide QRS, the use of the LVAD, RVAD, BiVAD for those patients with advanced stage. The ongoing therapy, remember those patients might be a high risk for DVT clots, so they need to be prophylaxed. And you restart or initiate your guideline-directed medical therapies, your SGLT2s inhibitors. I mean, looking at the talk Dr. Hadi gave, I mean, there is a huge room for improvement. That's the good news I got from his talk, because if 10% only are on SGLT2, means we have more work to do, but we can expect better results. Your MRAs, ACE inhibitors, ARBs, ARNIs, beta blockers. Remember, the SGLT2s and the MRAs have minimal hypotensive effect, so you could use them. Now, this is very important slide, the pre-discharge and the long-term strategy. The idea is to get your patients out of his misery and not to have him come back in a week or a month. So they are the decongestion goals: ensure net negative balance and stable weight before discharge. Medication adjustment: you tailor your diuretic dose for home use, monitor electrolytes and renal function. And the transition of care: some patients might need rehab or up titration of their chronic heart failure therapy before discharge. Now, these are the different scenarios. If the patient is hypoperfusing, if you look at him, if he's warm and dry, manage underlying cause, optimize the long-term therapy. If they are warm and wet, diuretics plus minus vasodilators. If they're cold and dry, hypoperfused, and not fluid overloaded, those you might challenge him with some fluid, and then you use your inotropes if needed. Progress to vasopressors in refractory hypotension. They're cold and wet after stabilization perfusion. Introduce your diuretics with caution. Consider inotropes if congestion persists, and you might escalate to mechanical circulatory support if unresponsive. This is just a repeat. The patient monitoring and follow-up. The ongoing management crucial to reduce hospitalization and improve outcome. Remember, every time the patient comes to the hospital, he might run a risk of 10% mortality. So you want these patients to be stabilized and reduce the rehospitalization. Patients' education on self-care and symptom recognition. This is very important. The best patient, the best doctor to the patient is the patient himself, because you're not with him. You don't know what he drank, what he ate, what's his body weight. So we give recommendations to keep an eye on their symptoms. Maybe the patient should weigh himself. And also you have to tell them, I mean, treatment of heart failure is not a medicine that you give. It's a lifestyle modification. It's, watching what they eat and drink, smoke cessation, maybe some walking exercise. And use also the telemetry monitoring and remote management. This is, improving the care that we give patients through the wearables, the iPhones, and other tele-monitoring methods. There are special population with comorbidities like patients with heart failure with complex comorbidities like diabetes, importance of the glycemic control and the use of SGLT2 inhibitors. Patients with renal impairment, those are your toughest patients to treat because most of the medication will affect their kidney function and potassium level. Patients with anemia, iron deficiency, or atrial fibrillation. The prognosis and risk stratification, we use different tools and scoring system aid in the risk prediction and management decisions. Clinical risk, like the MAGIC score, which gives you an idea about the 1 and 3 year mortality. The biomarkers, we spoke about BNB, the anti-pro-BNB, and the role of echo monitoring and sometimes MRI. I just want to say 2 lines. I know Dr. Hadi spoke about heart failure, predicted that we have in Jordan 100,000 patients with heart failure with an annual number of cases close to 8,300 cases. Our yearly mortality, unfortunately, is around 10%. And I got news from the International Diabetes Federation. Unfortunately, the rate of obesity in Jordan, obesity heart failure, among men is around 60%, among women is 75%. 75% of the Jordanian population are either obese or overweight. With that, I think I conclude. Thank you.
Thank you, Ayman. Ayman, come and join us here. Ayman, come and join us. We'll have the questions at the end. Dr. Muhanad will present the next speaker.
Thank you, Dr. Ayman. Thank you, Ayman. And I welcome Dr. Mohammad Jaabari, interventional cardiologist, who is going to join us now in the topic chronic heart failure. Dr. Mohammad is active member of the Jordan Cardiac Society and organizer of this great conference.
شكرا دكتور مهند for this nice presentation. السلام عليكم ورحمة الله وبركاته. طيب دكتور أيمن ما قصر بالacute heart failure. إحنا we will go to explain a little bit about chronic heart failure. The definition is very important regarding whether it's acute or a chronic heart failure. What's acute heart failure? Well said by Dr. Ayman, it's rapid onset or worsening of symptoms require urgent care. Regarding to the chronic heart failure, this is a classification diagram show the definition of heart failure, the stages, and the classification regarding to ejection fraction. But to diagnose it in generally, most of us must have a symptoms for heart failure. Yani we can diagnose heart failure without symptoms. Number 1, symptoms. Diagnosed is based on typical symptoms and signs. كنا عارفين symptoms of the heart failure, mostly the common symptoms dyspnea, orthopnea, PNDs. The signs is elevated GVP, pulmonary crackles, and peripheral edema. This is number 1, symptoms for the heart failure. Number 2, we have some lab test regarding the natriuretic peptide, PNP or pro-PNP is recommended to support our diagnosis. Next, please. Okay, and we have multimodal approach for accurate diagnosis. Then we have symptoms, we have a lab test, and we have echo. Echo is the cornerstone for assess the left ventricular ejection fraction. And also we have some advanced imaging such as cardiac MRI, invasive hemodynamics when indicated. Next, please. How to manage? No, the previous one, please. The previous one, okay. Next one, the management. Okay. The management overview, integrated management approach involving pharmacological and non-pharmacological strategy. I will strict a little bit on non-pharmacological strategy. The lifestyle for the patient for heart failure is very important. And the sitting with a heart failure patient is very important regarding to his diet, to decrease the salt, the exercise, the smoking cessation is very important. And then the pharmacological therapy tailored by heart failure subtypes. And also we have some devices advanced such as ICD, CRT, D for selective patient, and LVADs. Next. We will start with, next slide. We will start with number 1, heart failure with reduced ejection fraction. This is a diagram how to diagnose heart failure and the management of the heart failure with reduced ejection fraction. As we said before, symptoms is very important, elevated pro-PMP is very important, and the ejection fraction. The patient with left ventricular ejection fraction less than 40% with the symptoms and elevated PMP, this is mostly heart failure with reduced ejection fraction. And this is how to manage these patients. I will show you in the next slide, step by step, how to manage these patients. Next, please. Overview, diagnosis is very important. As we said, left ventricular ejection fraction less than 40% with the symptoms and elevated PNP. We initiate and optimize guideline medical therapy with the 4 pillars. Any patient with heart failure with reduced ejection fraction not on the 4 pillars, it's not a well managed, such as ARNI, beta blockers, mineralocorticoids, and SGLT2 inhibitor. And these should be ideally be started early as better for patient with heart failure, either simultaneously or in a rapid sustain, and up titration is very important to reach the target maximum tolerated dose as tolerated. Next. Reassess these patients and follow up is very important. We reassess him as clinical status, symptoms, lab tests, renal dysfunctions, إذا حصلت ولا لا قد ايه البوتاسيوم قد ايه الكرياتينين, and up titration for his medication over 3 to 6 months, and adjust therapy based on tolerability and response. Next. In summary, for heart failure with reduced ejection fraction, step 1, the diagnosis is very important. Step 2, start the medications, ARNI, beta blockers, MRA, and SGLT2 inhibitor. Step 3, once tolerated, increase the dose to the target or maximum tolerated level. Step 4, if symptoms remain despite maximum therapy, so switching to ARNI if not used originally, and we should use it at the first, add avapradine for elevated heart rate and, on beta blocker add-on, and evaluate for ICD, CRT, and advanced options dependent on the individually, every case by case. Step 5, reassess, monitor closely, and adapt treatment over the time. Monitoring the weight, it's very important. The sodium diet, the controlling for the sodium diet and his exercise, and symptoms tracking, and stop smoking. These are the steps, from step 1 to step 5 to treat and to manage heart failure with reduced ejection fraction. Next. What about heart failure with preserved ejection fraction? Heart failure with preserved, to diagnose heart failure with preserved, we have, again, symptoms for heart failure, elevated PNP, and the echo as a cornerstone. But the ejection fraction here is more than 50%. And this is heart failure with preserved ejection fraction. To summarize a little bit this disease, I make it in clusters. يعني, once you diagnose heart failure with preserved ejection fraction, look for the next one. Here, it's below 60 years old, or 60 to 90, or above 90. If it's below 60, he's youngest. So go to cluster 1. What's cluster 1 show? RAS, MRA, and ARNI, and lifestyle modification, weight reduction. But if the patient is between 60 and 90 and he's hypertension, we will go in 3 groups. What is it? Number 1, hypertension with atrial fibrillation without diabetes. Go to cluster 2. What is cluster 2? And it's almost 30% of our patients. It's atrial fibrillation management, ABC pathway, stroke prevention, rate, or rhythm control. And if it's obesity, hypertensive, diabetic, and low AFib, go to cluster 4. What's cluster 4? It's a SGLT2 inhibitor or GLP-1 agonist, diabetic control, hypertension control, and lifestyle modification. And if it's hypertensive, ischemic heart disease, CKD patient, concomitant diabetes atrial fibrillation, so go to cluster 5, which show SGLT2 inhibitors, GLP-1 agonist for diabetic control, hypertension control, and atrial fibrillation management and ischemic heart disease management. And if it's above 90% and he's heart failure with preserved ejection fraction, obesity, hypertensive with high cardiovascular burden, go to cluster 3, which is MRA decongestion, hypertension control, lifestyle modification, exercise, heart rate control, and atrial fibrillation and palliative care. This is a little bit scheme for the clusters and the management every patient in heart failure with preserve. To go it in details, next please. Again, we should diagnose patient with heart failure with preserved ejection fraction symptoms, elevated PNP, and confirmed by the left ventricular ejection fraction more than 50%, and exclude other conditions such as valvular disease, cardiomyopathy, or pericardial issue. Use diagnostic tools such as symptoms or signs or echo measurement and the diuretic peptide, and go for the algorithm as shown for HuF or H2 BIF and biomarkers, lifestyle management, risk factor optimization, and emphasize weight control. Again, obesity is very important in these patients, and control it, very important. Exercise, diet, low salt, and management of over or comorbid disease. Next. Pharmacological. Everyone know the evidence-based medicine for heart failure with preserved. We should now, it's class 1 indication for SGLT2 inhibitors. Also, diuretics has a role as strongly recommended for symptoms relief and decongestion. It's a class 1C. MRAs such as spironolactone and ARNI, sacubitril valsartan, may be considered in selective patients, especially those with left ventricular ejection fraction at the lower end of the preserved range or notable comorbidities, even though outcome data are limited. And phenylalanine is used in such selective patients. Next. Symptoms optimization and titration. We should tailor the diuretics use in these patients, especially to avoid hypovolemia and worsening renal dysfunction. And after SGLT2 inhibitors, consider adding MRA or switching to ARNI when symptoms persist or additional blood pressure control is required. Next. Also, strict control, as we said, the hypertension is very important, the atrial fibrillation, the ischemia, and the lifestyle, as we said before. Next, please. And this is a little bit diagnosis of what I said, the key action, the diagnosis, the lifestyle and risk factor, the pharmacotherapy, the adjuvant pharmacotherapy, and the comorbids and symptoms management and the follow-up. Next. So, what are the challenges we are facing here in Jordan when treating our patient with heart failure?
Muhammad,
Number one, we should...
20 seconds.
Just 1 minute. Okay, just desire to do more and without doing harm. To desire to do more, improve outcome and manage symptoms of frequency and increase options, especially for elderly patients. Without doing harm, go good safety profile, preserve and follow up his kidney function, and minimal contraindication due to polypharmacy. Next. And this is very last 2 important slide. What are we facing challenges in Jordan? Number 1, not all centers in Jordan perform pro-PNB testing. So we should work in this. Number 2, some centers face difficulties in reporting cardiac MRI results. Number 3, financial constraints affect the availability and maintenance of the HeartMate device. Next, please. And last slide, the medical therapy. Not all patients are receiving the complete four-pillar therapy, number 1. Number 2, up titration of the medication such as ARNI remain challenging in some centers. And regarding the patient with heart failure with the preserved, some centers face difficulties in the proper use of echo for accurate diagnosis. Number 6, activate specialized heart failure clinics with monthly patient follow-up and highly trained nurses to ensure optimal care and outcome. And lastly, artificial intelligence. It is important to implant artificial intelligence in the diagnosis and management of heart failure, particularly heart failure with preserved ejection fraction is still limited and require further development. And thank you next for listening.
Thank you. Thank you, Muhammad. Muhammad, come and join us here, please.
Thank you, dear
هو الكنت
هيك واضح. Thank you, dear Muhammad. Let's welcome our next speaker, Dr. Qais al-Balbisi. Dr. Qais is a consultant of cardiology at Jordan University. He's also the head of scientific committee at Jordan Society of Cardiology. He will tell us today about the diagnostic tools in the diagnosis of heart failure.
Thank you, Dr.
The
Rashid.
stage is yours.
Great introduction. Appreciate it. Hello, everyone. All right, so I'm going to focus today on the diagnosis of heart failure. So basically, next please. Next slide. All right, so I'm going to touch base very quickly on the classification of heart failure so we can reach how to diagnose heart failure. Then a little bit about diagnosis of heart failure with reduced ejection fraction versus heart failure with preserved ejection fraction, and some of the challenges on the diagnosis of heart failure with preserved ejection fraction. Next. So, classification of heart failure. Now, next please. The classification of heart failure, it really actually depends on what is your clinical question. You should ask yourself, what am I classifying? So, am I classifying disease progression? Then it's the ACC-AHA staging. Am I looking for functional capacity? Then it's the NYHA classification. Am I looking for the pump function? Then it's the EF. Or am I talking about the hemodynamic profile, Forrester's classification? Or am I talking about causality and etiology, morphofunctional causes? There is the MOGAS classification. And ultimately, am I talking about an advanced heart failure patient, and comes the INTERMAX classification. So there are different tools, different classification systems. The question is, what is my clinical question? Next, please. So, first one is the staging of heart failure. Staging of heart failure is more or less like staging of cancer. Once you hit a stage, you can't go back. And it's more about risk. First one is the at-risk patients, then they're pre-heart but never been symptomatic, then symptomatic, then advanced. And each stage carries a certain prognosis and a certain disease progression and a certain approach to management. Next. Of course, if you look at stage C, there are also different trajectories. So each heart failure patient might go in different ways. It might be a new onset heart failure patient. He might get better, so he goes into remission, or he might continue to have heart failure but relatively compensated, so that's a persistent, or he can become worse, and that's a worsening heart failure. So we have staging and trajectories for our patient. Next. Now, this is the most commonly used classification for heart failure because, as you could see earlier in the both lectures, a lot of the management depends on what type of heart failure am I dealing with. So, the initial classification, heart failure with reduced ejection fraction, less than 40. Now that has two trajectories. Either it gets better, which we call heart failure improved EF, or it stays the same as reduced. Then you have the mid-range or mildly reduced. I like the mildly reduced better because mid-range gives you a false sense of security, which is between 40 and 49. Then also that has different trajectories. It can get worse, or it can stay the same, or it goes into remission. There are certain other resources that might call it heart failure with recovered EF, but recovered again gives you a false sense of security. Probably remission is a better terminology. And ultimately, the enigma of all heart failure, which is heart failure with preserved ejection fraction, where you have a higher EF more than 50 with different trajectories. Next, please. All right, so heart failure with, the other question is my hemodynamic profiles. So, this is the Forrester's classification. Where is my patient? How compensated is he? What's his forward perfusion? So then you get warm and dry and cold versus cold and wet. Worst case scenario is when my patient is wet and cold. The best when he's compensated and he's warm and dry. So, next please. Then there is this complicated MOGAS. This is more for etiology of cardiomyopathy and really not a day-to-day basis, but it kind of gives you also an idea of the genetic basis. Next. Ultimately, there is the advanced heart failure profiles, and INTERMAX kind of tell you where is my patient. Next. Okay, so I like this slide. So this is when is my patient advanced heart failure? Where do I need to go and seek more advanced heart failure care? Not the usual cardiology, more heart failure specialization. And the acronym is I need help. I for intravenous inotropes, N for advanced New York classification or severely reduced peak VO2 less than 14. E is for end organ dysfunction, the other E is for EF less than 35, D is for multiple defibrillator shocks. HELP, hospitalization more than once in a year. E is edema despite escalating diuretics, low systolic blood pressure, and the P is when I'm starting to down titrate my medicines because my patient can no longer tolerate these medicines. That patient, I need help, needs to be referred to advanced heart failure care. Next. So this is again the Intermax in kind of more easier words to understand. The Intermax one is a crash and burn. The patient is going to die in hours. These need to go immediately for LVADs or mechanical support devices if available. Then you have the sliding on inotropes, stable but dependent, then frequent flyer, and then ultimately walking bound. So these are again for advanced heart failure. Next. Again, so this is basically a brief review of different classifications and how I'm going to look at my patient when I'm trying to approach them clinically. Next. So again, back. So what is my clinical question? First of all, is my patient in heart failure or not? So I need the diagnosis of heart failure. Second, what type of heart failure are we dealing with all those classifications? What is his status, hemodynamically and functionally? What is the cause of his heart failure? And then how am I going to treat him? Next. All right, so I'm going too fast. I don't know my time. What is the time?
3.5 minutes.
Thank you. So, first of all, this is the ACC-AHA, which we adapted as the guideline and approach. It's easy, it's nice. It goes initially with physical history, ECG, and labs. Then you incorporate BNP within it. It's not a must. Unlike the ESC, which usually they do require BNP as part of the diagnosis. Of course, echo is a crucial part to go through those questions that we talked about. Then once you diagnose your patient, you're going to also classify him into which category, HFrEF, HF mid-range, or mildly reduced, and HFpEF. Then you evaluate for causes. Next. So this is the ESC. Next, I'm going to skip that one. All right, this is the universal diagnosis. So again, we have to look at 3 points to diagnose heart failure. Number one, next, symptoms. And we all are aware of what symptoms and congestion symptoms of heart failure and signs. Next, I need a structural evidence that there's a problem. Either my EF is less than 50, or an E to E prime, which is high, or an abnormality in the cardiac function, and an evidence of objective evidence of congestion, either elevated BNP or a elevated abnormal chest X-ray, echo, or hemodynamics. Next. All right, so there are other causes for elevated BNP. So we should always be aware that not every elevated BNP is heart failure. So the clinical picture is important. There's also causes for low BNP, such as obesity. Next. All right, so HFpEF versus HFpEF. Next. HFrEF is an easy disease. Next, please. So you have a decreased pump, causes neurohormonal problem, you treat it, you get better. HFpEF, like Dr. Muhammad said, next please, is an amalgam of different diseases. It's not really one disease disorder. They all ultimately end up with congestion and a normal EF, but they're different diseases. That's why we haven't found a clear one treatment for all of them. Next. So there are different ways, different tools to diagnose them. I find this tool easy to remember. It's the ACC one, which is HFpEF, but H gets 2, heavy hypertensive, atrial fibrillation, pulmonary hypertension, elderly, and filling pressures. If you're 2 and less, you're low risk for HFpEF. If you're 6 and above, that's very high risk. In between is a gray zone where you need to take a next step with either stress echo or invasive hemodynamics. Next. Now, there is a more advanced protocol suggested by the European Society of Cardiology, but again, it's a bit more complex. It's the HFA-PAFFF. You go initial workup, then next. You go for, next please, the functional and morphological and biomarkers, depending whether they have AFib or not, with different major and minor criteria to calculate. And if it's above 5 points, you got the diagnosis. 2 to 4 points is kind of in the middle. If you don't get the diagnosis by this, next. Then you go for the next step, which is advanced workup through an echo, stress echo, or invasive hemodynamics if the stress echo is not available. Next. Ultimately, you look for the etiology. So, next. Again, how do you diagnose HFpEF? Next, please. Focus, it has to make a story. Next. So, you have 2D echo parameters, LA size, LV size, LV function, right-sided pressures are very important, and diastolic parameters. We should all learn this. Next, please. And focus on them. And once we go, this is a nice algorithm. If we have less than 50%, usually this is normal diastolic function, more than 50% of these 4 points, that's diastolic dysfunction. In between, you probably need more testing. Next. So I'm going to stop here.
30 seconds.
I'm done, actually.
Okay.
All right, so I'm done, and I'll leave it for questions. There's a
Thank
lot
you.
of things that I could talk about, but again, this is meant as an introduction to how you diagnose and how you approach heart failure.
Thank you,
so
Qais.
much.
Come and join us here, please. Thank you. All right, so I think we have 10 minutes, Hadi, for questions. 10 minutes. Okay. Any question from the panel? I have a question. تفضل دكتور. So من دراسة الدكتور هادي اللي ورجاني إياها, احنا we know that from the literature when we have one HFref we should have one HFpEF, the 1-to-1 ratio. But in Jordan we saw the number is 60% HFref and 30% HFpEF. So we are losing HFpEF diagnosis. So Ayman, we have students here. MashaAllah, طلع. Tell them in few words how not to miss HFpEF because we are missing them. Okay.
We look at the risk factors. And back in the days when, 100 years ago, when we were in med school, the ratio was 1 in 14. One case of HFpEF compared to 14 HFref. Now, in the Western society, it's almost 50-50. So to find the HFpEF, you really have to look at the risk factor, which is age and obesity, which is really a pandemic in our country. I think those patients are sometimes, like Dr. Hammoudeh said, they're more difficult to diagnose because a lot of us use B&B. Guess what? B&B get destroyed by fat cells. So heavy set people might be in failure and their B&B is probably within normal range. So it's really that suspicion of index. But I think with the statistics that we're getting that 75% of the population in the next couple of years will be either obese or overweight, HFpEF might really supersede the HFref in terms of the ratio. I just want to make a comment on what Dr. Balbisi said. We have HFref, which is EF below 40, HFpEF, which is EF, which is systolic dysfunction. The HFpEF is EF above 50, which is diastolic dysfunction. And this mid-range, they came up with this mid-range because it's really a mixture of both. And we're confused what to do with these. But I think this is for probably study issues. And I wonder, like, the way we say ejection 50 or 40, we eyeball it most of the time. So to say this is 49, this is a mid-range 50, this is a HFpEF is a little bit of a stretch.
Thank you, Ayman. Dr. Muhanad, you have a question?
I wanted to just make a comment about, the diagnosis of HFpEF. That's the thing, it's underdiagnosed, considerably underdiagnosed. And as you said, if BNP is normal, it doesn't mean you do not have HFpEF. You could easily have it, and you need to look into the other parameters.
Thank you. Muhanad.
Thanks to all our speakers. I have a question. Every one of our speakers mentioned the role of BNP in the diagnosis of heart failure. I want to ask, is there a clinical difference in BNP and NT-proBNP?
In the numbers, yes.
In the diagnostic tool, in the levels we measure, because is it influenced by inhibiting the neprilysin?
Okay, so no, both have been mentioned. Both are useful. The numbers are different, of course. You know, for the NT-proBNP, it should be less than 125 to consider it normal, above is abnormal, and less than 30, and that's in an ambulatory setting. If you're talking about decompensated patient, NT-proBNP becomes above 300 versus that one is above 100 for BNP. Now, the pathophysiology, NT-proBNP is the precursor, so it doesn't get affected by a lot of the medicines that we use to treat heart failure, such as the ARNIs, while BNP can be affected, so that's why we rely on NT. But both are produced, both are, you know, it's the metabolism of it.
Also, BNP is affected through the treatment with ARNIs in the measurement just.
Yes, yes, exactly. So BNP is affected by, because BNP is metabolized by neprilysin. So neprilysin inhibits your metabolism, which falsely elevates your BNP, while NT-proBNP is a production component. So it's not affected by your degradation.
Totally agree, Qais.
For the short-term follow-up, is NT-proBNP is more effective in this case?
If you're on ARN, yes.
Yes.
One final question before we adjourn. Again, from the Jordan heart failure study, we noted that only 10% are using SGLT2 inhibitors, which are class 1 indication for all the HFrEFs, HFpEFs, and the mid-range. And even a little more confusing number or more distressing number is the use of the 4 pillars in one patient is seen in less than 1%. So Qais, again, for the students, in a few lines, how do you, why are we not using SGLT2 inhibitors despite being the safest, the easiest to use, and you can use them day 2 after heart failure admission?
Why? We should. I mean,
what is the gaps or the hurdles between the guidelines and the actual life we have?
I got you. So basically, first of all, availability and expense. In a lot of cases, a big part of our patients are treated in the public sector, which has limited fundings, and these are sometimes, in a lot of cases, expensive medications, so they might not be readily available. But still, we need to push to make them available because they do really help both in all spectrums of heart failure. Actually, the only ones that have been proven to be useful for HFpEF are SGLT2 inhibitors. So that's number one. Sometimes, again, as we could see, there's a very low compliance or tendency for our patients to be on all 4 pillars, despite all what we talk about. So that's education for the people, education for the physicians, education for primary care physicians to kind of overcome, and patients need to be on the 4 pillars. And ultimately, there are certain patients who cannot tolerate them, but those are a small minority, like if you have genital infections or, you know, urinary tract infections, or if they have DKA, but, you know, those are very minimal. Those are not the majority, and those are exceptions rather than the rule.
Also, one point, Qais, the SGLT2 inhibitor, يعني what's in some minds that it deteriorates the kidney function. On the other hand, the SGLT2 inhibitor is improving the renal function.
Okay.
This is a very important point.
So for the sake of time, I think we have to adjourn. We thank all the speakers and the moderators. Thank you.
Thank you.
Thank you very much. Let's switch gear here. Let me call upon Dr. Firas Badr, please. Is he here? Oh, here you are. Please join us here. Firas will be a session coordinator with Dr. Hanna Mathame